welcome back. So we just scare out too many people. So did everybody get a chance to get into the video in the shell? Did you guys get a chance to see that chapter 1's here? It's also in next week, in chapter 2. Okay, so I know some of you, actually quite a few of you didn't have a textbook. You're really going to need that textbook. So pre-quiz 1 is due Monday by noon, but it's a holiday. So my suggestion is for you to take pre-quiz 1 anytime after this lecture. And you have maybe a little time to review the notes, think about the lecture. You've done the reading, that's the reading, chapter 1 there. On the syllabus, if it says chapter 1, read the whole thing. If it says chapter 1 and page numbers, just read those page numbers. Like, I'm not going to assign you readings that are extraneous or superfluous. Make sense? Okay, so that's there. We've got today, and then we've got next Monday in cell injury and death. And so the way the quizzes would work is if it was a week that we didn't have a holiday, Monday you do the pre-quiz, and you come to lecture, and you finish up hearing about cell injury and death, and then you'd hear it again on Wednesday, and then Friday you take the post-quiz. Make sense? Now, if you want to work ahead, all the pre-post quizzes are available. They're posted and they're open, so you can work ahead. So if you know that there's a date when you're going to be gone, or you're going to miss class, you can work ahead, or you can be diligent about watching the video post. And I posted Monday's video. I can't remember if I did it Monday or Tuesday, but it was it's definitely up on YouTube. Anybody get there and can see where it is? Anybody check it, make sure it's working? Nobody looked at the, like, you guys know all about the syllabus. You didn't need to rewatch it. Like, wait a second. What was the name of the class again? Yeah, okay. All right, good. So you might want to do that today after the lecture, or tomorrow before you do your pre-quiz, so you have it fresh in your mind, okay? They changed the YouTube platform. They always change the YouTube platform, so it took me a little while to figure out how to repost stuff, but I think I understand it now. So I think I posted it like 3 times, and I had to delete the 2 that were extra. Okay, before we go into the material, remember, these are super corny, so you got to think kind of like when you were a kid, all right? You with me? These are bad dad jokes. Why was 6 afraid of 7?
7, 8, 9.
7, 8, 9. Look at you guys. You're already rolling. You're rolling. Why are animals in the ocean so healthy? Why are animals in the ocean so healthy? Something over here. Because they get their daily dose of vitamin C. There you go. All right, last one. You ready? What do you call the hair under a cow's nose? A moustache. Oh, come on. This is going to be a tough crowd here. I'm going to tell the little ones, you're going to have to work harder. Okay. All right. We did not sign up for this class to hear you do jokes. Okay, just a little icebreaker. Helps me connect with you guys in a goofy way. And actually, it's kind of funny, but one of the psychologies of teaching is trying to connect with your audience. So if there are moments where I'm making a fool of myself up here, it's not a bad thing. It's at my expense, but you might remember it better that way. Okay, if you can connect corny, goofy, funny, okay? Usually boring, bland, right? Sad. You don't want to remember those things, but all the other stuff might help with connecting the dots on the information. So let's talk today. We're going to launch into material. This is really our first genuine lecture. What are the 4 aspects of pathology? And so remind us, we defined pathology on Monday. So someone tell me, what is pathology? Or you can phone a friend, that's fine.
Etiology.
What's that?
Etiology.
What is pathology? Well, what is pathology? That's what I'm asking. Etiology is an aspect of pathology. These are 4 aspects of pathology, but let's back up. What is pathology?
The study of suffering.
Study of suffering, the study of diseases, okay? So in the Greek, logos is study, okay? And the Pathology is going to be the study of suffering. So it literally translates into the study of suffering, where we're going to be looking at different types of diseases. So the four that we're looking at here: etiology, pathogenesis, morphological changes that are both micro as well as macro, and then clinical significance. So these four are really valuable for you to know, right? So these four terminologies of etiology, right? And then we've got pathogenesis. Then we've got morphological changes. And then we have clinical significance. So this semester, we're going to have diseases that will walk through every single one of these topics when we're studying the disease. So we're going to talk about the etiology. So what is etiology? What does that word mean? It's from the Greek, meaning giving a reason for. What does that tell you about from a disease standpoint? What would etiology be? It's the causation or the origination. How is that different than pathogenesis? What's pathogenesis?
Disease caused by bacteria.
Okay, so that would be a very specific example. Bacteria infects the tissue and causes a problem. Okay, so that's the mechanism by which the disease continues. That's pathogenesis. So pathogenesis, it's literally the beginning of, or the creation of the disease. And then morphological changes here, both at the gross and micro level. So gross is going to be macro, and so we'll look at gross images. Not gross in the sense of disgusting, but they are sort of disgusting when you think about it, okay? Like when I'm in my office at home kind of looking through slides or research, and you have the big monitors nowadays, and the kids walk by, they're like, ooh, right? Like, Dad, it's disgusting. But gross in the sense of macro. Okay, so we're going to look at tissue, and we'll look at macro changes that take place. What does that mean? Well, maybe the tissue swells. So maybe the tissue is red in color. It's inflamed. Okay? It's tender to touch. And then micro, that's microscopic. We're going to look at microscopy as well. Is there a question back here? Max, do you have a question?
Yeah, you answered.
Okay. So gross is saying macro, and micro is referring to microscopy. Okay, we'll look at both. And here at this picture are three pathologists. And so this is my dig on pathologists, right? So I'm a Ph.D. I'm not an M.D. So I do a lot of pathology work, but it's all research generated. And a pathologist who's an M.D. is going to actually take biopsies of patients and actually do analysis and give a diagnosis and a prognosis. But the joke in medicine with pathologists is their bedside manner isn't the great. Look at the bedside manner of these three pathologists. You think they're even saying anything to each other? They're always staring at the microscope, okay? So usually pathology is in the basement of the hospital. They don't ever go up and talk to patients. They just analyze tissue. But it's super fascinating, okay? And not all pathologists have horrible bedside manner, but that's always kind of the joke. So here you've got three pathologists on a training scope where they're all looking at the same piece of tissue, and the individual on your right is actually got a booklet of slides and is driving, and these two are observing what's going on under the microscope. And so that would be microscopic changes. Then the last one is clinical significance. In a disease state, there's going to be some clinical sequelae. That's just a fancy way of saying there's some clinical problem. So someone over here shouted, you're sitting back there in the blue and yellow. Yeah, you just turned your head. Thyroid disorders or diseases. Remember we talked about that? You were shouting out some diseases and you said thyroid. So in thyroid, if your thyroid is underperforming, it's not making enough thyroid hormone, what's the clinical significance of that? Can anybody guess?
Could not be like functioning the same, or there's not competition.
Yeah, so you're going to be functioning the same. That's a safe answer. The thyroid hormones help regulate metabolism. So low production of thyroid hormone means low metabolism. So lethargy, you're tired, you're sluggish, probably weight gain, okay? So that's the clinical significance. If it's a child, they might be underdeveloped. They're not going to be maturing at an appropriate rate. That's hypothyroid. We'll get there. But I'm just giving you an example of a clinical significance. Okay? Some of you were talking about different types of diseases. Someone in the back said cancer. Okay? And you're not here today, but maybe you'll see this on the video. You said cancer. So what's the clinical significance of cancer? Now, this day and age, in this size of a classroom, probably, I'm guessing 75% or greater of this classroom has been impacted in some way by cancer. Okay? That's just how prevalent it is. So you guys can tell me absolutely, well, what kind of cancer are we talking about, Dr. Keller? And you could go off probably for a while on a rant about the clinical significance or what's going on with that cancer patient. So every disease that we're going to study is going to have some sort of clinical sequelae. You guys with me? So these four kind of guiding principles, if you're asking yourself as you're studying for the exam, hey, what's the etiology? What's the pathogenesis? What are the morphology? That just means structure. What's the micro and macro, or the micro and gross changes that I should be able to understand? And then what's the who cares? That's clinical significance, is the who cares. All right, so first disease example that Richard was alluding to. Okay? And we were supposed to get this on Monday, but I was slow on my introduction, and so we're catching it today, which is fine. Okay? Barrett esophagus. Barrett esophagus. Now, there's a couple of different things that we need to talk about with respect to Barrett. There's four aspects of this disease. Now, the four aspects of this disease, can I erase this here? We don't have, this room doesn't have a lot of whiteboard space, I discovered. It's all behind the screen. So, unless, oh, this is a whiteboard. Okay, well, I'll have to remember, that looks like important stuff though, like, maybe I should read it, but it says Trek Mount Everest. Apply today. You just apply? Probably should train, but okay, so four aspects of the disease of Barrett. So, number one is this has its roots, and I asked you to look at this. Did you guys take a peek at this? Did you guys look at these slides? A couple of you, like three, thank you, the three of you, okay. So this is going to become more important when we, and that's the pre-quizzes, because you're going to tell me what's going to happen, I know it, is students are going to say, man, I feel like you're going so fast. I say, well, the reason you feel like I'm going fast is because it's the first time you're hearing it. And so if you just look at the pre-quizzes and you do the readings and you take a look at the slides before you show up, you're going to remember a lot more than if you just hear it for the first time right here. I promise you that's going to be the situation. Okay? So, four aspects of the disease. Number one, this has its roots in gastroesophageal reflux disease, otherwise known as GERD. GERD. Gastroesophageal reflux disease. So what is that? That's heartburn. And so that's when one of the sphincters that are in the esophagus, usually the lower esophageal sphincter, has regurgitation, where it doesn't completely close. And so the stomach contents are actually kind of backwashing or retrograde flow up into the esophagus, and you get this burning sensation on the esophagus. Heartburn is what we call it on street language. Reflux disease or gastroesophageal reflux disease. Well, imagine if you had that for 10, 20, 30 years. Okay, so just keep that in your mind. So 10% of these GERD patients develop Barrett. And you're still wondering, like, what the heck is Barrett? So 90% have no issues. Okay, but you really don't develop Barrett unless you have had a chronic condition of GERD. Okay? Number three, prolonged injury. So the GERD is lived with. So how many of your family members say, yeah, well, I get heartburn, so what do you do about it? Nothing, I just tough it out. Okay? Yeah, I'm a guy, I mean, come on, it's not that complicated. Oh, I'm a splinter, I got a splinter, pal. Right? So they just tough it out. And so now chronic exposure is number three. This is the aspect of chronic nature. And we're usually talking about greater than 10 years of wrestling with GERD. And then the last, but the most dangerous, is the aspect of what happens known as metaplasia. Cellular metaplasia. So cellular metaplasia, what is cellular metaplasia? This is from the Greek that means change in form, is what the word translates to. So metaplasia, cellular metaplasia, is where a cell type is going to transform into a very different cell type. It's going to differentiate into another cell type. But in this situation, it's pathologic. It's not supposed to do that. Okay? So, chronic GERD, 10% develop it. We don't really know why it's only 10%. It's probably some combination of they're predisposed to developing this disease, and then there's an irritation, or there's a stimulus to cause cellular injury. And that's what we're going to get into next, is cellular injury. But the biggest issue is this is a risk factor for esophageal adenocarcinoma. Esophageal adenocarcinoma. And I misspoke. Our cancer friend is in the room. You're sitting in a different spot and you're dressed different, so I didn't notice that until now. But this is a pre-form of cancer for our cancer friend that was talking about cancer on Monday. Esophageal adenocarcinoma. Okay? It's a precancer. It's typically benign, meaning it's not malignant, it's not going to go anywhere. But it can be dangerous if it's left unchecked. So this is kind of a big deal. This would be considered throat cancer. This is what it looks like. So here's morphology at the gross level, meaning kind of macroscopic. But it's a laryngoscope that goes down and looks at these images. And so you've got two images. You have normal on your left, and then you have Barrett esophagus on your right. And so the normal, you know it's normal because there's these areas of white glistening tissue. And that's the epithelium that is well hydrated and slippery. Think about the throat, right? You chew and masticate your food, you swallow the bolus of food, it needs to go down the throat slippery and smooth. And what's the epithelium that's typically present in the throat, in the esophagus? You guys remember this? Is back into 201. We looked at different tissue types. The back. You don't have to raise your hand, but I love it. Stratified squamous. Very well done. I heard a lot of, so I think you guys are well doing that. But in the back, a little bit more bold. Saying it. So please don't be afraid to ask questions, raise your hand, interrupt me. I want to make sure that if you have a question, I don't want you to not get a chance to ask it, okay? If it's going too long, I'll say, hey, we got to move on, come see me after class. Don't be offended by that. But generally speaking, I want to take time for questions. Yes?
What's the reason the sphincter doesn't close all the way?
So the question is, the other thing is a lot of times I'm going to repeat the questions for the audio. So if you're watching this again, you can hear the question. Does that make sense? So the sphincter, the question was, why does the sphincter not always close? So we're talking about the lower esophageal sphincter. So this is smooth muscle. And as we get older, our muscles lose their muscle tone. Okay, throughout the body. It's not just this particular sphincter. Okay, so in older patients, geriatric patients, they'll lose even bowel control, they'll lose urinary control. So this sphincter, obviously, in these patients, and you'll see here the risk factor, middle-aged males, this is probably one of the first muscles that is kind of wearing out as we get older. Good question. Okay, so normal stratified squamous epithelium, you see all the red in tissue that's replaced with, or that has replaced the white glistening tissue. So we can see that this is not stratified squamous anymore. You can see that, Keller? Well, I know that because stratified squamous has this kind of appearance when it's wet. Okay? And so this should be shiny, and it's not. Now, we can go from gross, we can go to microscopic to look a little bit more closely. But before we get that, let's take a look at the morphology progression. So this would be esophageal adenocarcinoma. Do you see this giant lesion in the lumen? So this is what we want to avoid from developing, okay? Let's look at the histology. Bless you. So the histology of Barrett, is we've got these microscopic metaplastic changes. That means we get a cell type that changes from one form into a totally different form. Okay, let me prove that to you. We just heard in the back accurately, stratified squamous epithelium in green. This is a biopsy, so they take that laryngoscope, they would come down, they would grab a biopsy of tissue, and they'd send it away for pathology to the basement, right? My father-in-law actually just had this done, and he does not have Barrett, but this is not his sample, okay? But I am not past like showing my family's tissue samples on the screen, so just beware. I'll let you know when they show up. This is stratified squamous epithelium here, this green. And over here in the red is we have, and this is literally microns away. Remember, this is a tissue sample and we've blown it up under high magnification. And these are the types of pictures you're going to see on that histology DVD. And this is testable material. I mentioned, you guys might not have caught this, but I mentioned at the end of lecture, I will only write my test questions based upon my lectures, right? Sorry, we're still kind of getting used to this room, including myself. So if I cover it in lecture, it's game on. If you read a little segment in the text, but I never mention it, you don't have to worry about it. Okay? Am I going to find some obscure little clinical box in your chapter and write essay questions on that? It's everything that we cover in class. That's why I want you to come. That's why I want you to watch the lectures. I want you to have resources like the video of what we cover. And so it's actually for me too, because you might say, hey, we didn't cover that. And I can say, well, let's look at the video, right? And I might be wrong, and I might be right, or you might be right. So these images that you see in lecture could show up on the exam. So it's good for you to study these and understand them, ask questions about it. So this type of tissue here, it may be difficult to see from your seat, and I don't know if you have your iPads open or you have your printouts where you can see it, but what we're looking at is goblet containing epithelium. Where did you see goblet containing epithelium? In the stomach or in the duodenum, right? So the goblet cells release a mucus that coats that epithelial surface that has hydrochloric acid, because that's the digestive contents of the stomach. And so when gastric emptying happens, the stomach lining needs this protective layer, and the duodenum, or the small intestine, the first part of the small intestine, needs the protective layer of the goblet mucus to prevent erosion of the epithelium. So this esophageal tissue is gone through metaplastic change to now be goblet epithelium, which is a columnar epithelium that you find in stomach and duodenal tissue, not esophageal tissue. So pathologically, your pathologist would take that biopsy and say, yes, we have a confirmation of Barrett. The doctor says, I think the patient has Barrett. I'm seeing this. I'm seeing this giant nodule. I think they have Barrett and maybe esophageal adenocarcinoma. Let's take a biopsy sample of that. Let's send it out for pathology. And a couple of weeks later, I get this back, and the pathologist says, diagnosis confirmed, goblet-containing epithelium, diagnosis, Barrett esophagus. Make sense? That's how it works. Questions?
So why do the goblet cells indicate this, or do they?
No, the question is why the goblet cells? Why are they so important? Why does it indicate a Barrett diagnosis?
They're normally in the throat anyway.
No. They would be in the stomach and the small intestine.
Uh-huh.
But if usually the food's going this way,
Yeah.
and you have hydrochloric acid in the stomach, the only time you have HCl coming up is when you have regurgitation. Right? Jimmy, does that make sense?
Yeah.
So this shouldn't be there. That is a pathological tissue. If we're taking biopsies lower down the GI tract, then you're correct. But because we're in the throat, the esophagus, we shouldn't see it.
Okay, and it comes from the stuff coming back up, and it's developed from that.
So that's the etiology. Is the origin is from metaplastic change due to HCl, Now, the pathogenesis is the cells mutate. You with me?
Yeah.
So the cells mutate. What cells? We're going to talk about it here in a second. The cells mutate to start making this epithelium rather than this epithelium. You with me?
Yeah.
Okay. Yes?
So this is the body compensating, right?
This is the body compensating for the injury. That's exactly right. And that's what's setting us up for this next lecture on cell injury. Is your cells are under injury 24/7. 24/7 your cells are under injury. Because we live in a very dangerous environment. And they compensate. And oftentimes they can compensate favorably. But if it's aggressive over 10 years of acid exposure, does it surprise you that the cells mutate to protect themselves to form goblet epithelium? It's pretty amazing that the body does that. But this is kind of the root cause of why we have some of these pathologies. Yeah?
So it comes into the mass to prevent backflow, but if cancer stops, when it can't stop going.
So this mass isn't necessarily forming to prevent backflow. This mass is forming because the epithelium that's turning over to make more goblet cells is mutated, it's overactive. So it's continuously making new tissue beyond what it normally should, and then what ends up happening is you get a ball of extra tissue. We call this a neoplasm. We'll get there. But we call that a neoplasm. That's a good question. Okay, yep. For Barrett, yeah. For Barrett esophagus, it'll always be goblet cells. Now, we'll look at some other examples in the next lecture of cellular changes or metaplastic changes that take place that aren't goblet epithelium. In fact, some of these cells become fatty, lipid vacuoles of fat. That happens a lot in cardiac tissue and in liver tissue. You get a fatty liver when you have a lot of toxic injuries to the liver. Okay? So, for example, alcoholism or poisoning of the liver, the hepatocytes, usually the liver primarily feeds off of metabolism of fat. And so what ends up happening is you get a lot of lipogenesis in the liver, and you get a fatty liver. And so you might have heard about that with people that are severely alcoholic, they have a fatty liver, or in patients that have a lot of toxin poisoning, like from Tylenol poisoning, you'll get fatty liver and damage. Okay. So Barrett esophagus, to the question up front, what's going on here with respect to pathogenesis? How does this deleterious situation propagate and why? Well, you get an alteration of the stem cell. So this is an epithelial tissue. So let's take an epithelial tissue that you're maybe more familiar with than the esophagus. Let's look at skin. Skin epithelium. There's different layers, and there's a stem or a regenerative layer of skin. And what was that called? You guys remember?
Basement.
It was at the base of the membrane. It was called the stratum basale layer, and that would turn over and give rise to superficial layers, and then the skin would slough off when it got old. All epithelium does that. So at the basement layer of the epithelium is where the stem cells are located. So if we go back here, the basement layer is this dark purple nuclei, or dark purple colored stained cells are the basement layer progenitor cells. Those are the stem cells of the epithelium that belongs to the esophagus. So these guys go through this prolonged injury, and instead of differentiating into stratified squamous, they say, forget this, I'm going to protect myself. Let's change a little bit and start making mucus so that we can defend ourselves against this hydrochloric acid that keeps coming up. Okay? So the prolonged injury to the stem cell layer is what triggers it to mutate, change, go through metaplasia. So, quick review, what are the stem cells? What's a stem cell? So, there's basically two main types. There's really three categories, but there's really two main types. There's either embryonic stem cells, or there are adult-derived stem cells. So, embryonic stem cells come from the embryo, and adult-derived are after the developing fetus is born. Now, there's very young neonatal-like adult stem cells, and we would call those stem cells that are derived from placental tissue, from umbilical cord blood, but technically they're not embryonic, so they're considered adult. So embryonic and adult are the two main categories. Now the third category scientists have discovered are what are called induced pluripotent stem cells. And so we abbreviate these IPS cells. Now these are adult-derived stem cells, but what happens is you give them transcription factors, and you don't give it to them, you transfect them with transcription factors that modifies the genome to make them behave more like embryonic cells. So these IPS cells are adult-derived, meaning they're not an embryonic source, but they're inoculated with transcription factors that make them behave like embryonic stem cells. So in this tissue that we're talking about embryonic, we're talking about adult stem cells in the esophagus of a 40-year-old male. It's not a trick question, but I gave you the answer right there. These are adult stem cells, and you and I, we have adult stem cells everywhere. And when those adult stem cells mutate, you can have some problems, okay? So that is going to be a theme that we're going to see. That happens in cancer, right? That happens in a lot of diseases that we're going to look at. Okay, so Barrett esophagus, here's the clinical sequela. This is what you guys care about. Maybe you're like, oh my gosh, this is so boring. You just get to the good stuff. Well, here's the good stuff. Clinical features, age 40 to 60 typically. White males, that's the ethnicity and the gender or the sex that tends to be most at risk. It's a localized ulceration, and if it's 3 centimeters of Barrett mucosa, you're 30 to 40 times more likely to develop esophageal adenocarcinoma. That's what goes in that blank. So what we're saying is the more real estate of the esophagus that's Barrett, the greater the risk of developing the adenocarcinoma. The advancement that takes place as this gets more aggressive, it advances to dysplasia, and that gets you closer and closer to a true cancer state. So dysplasia is a term from the Greek that's an abnormal growth, okay? An abnormal growth that takes place, like that little ball of tissue that you saw in the middle of the esophagus. Now, this isn't the only place that this can happen. So this is at the other end, right? So this is on the other end. This is in the duodenum. So we have the stomach, and we're talking about the esophagus, which is, proximal, distal, or downstream to the stomach is the duodenum, and this is where this tissue biopsy is coming from. And this is also an example of histology on the DVD. So if you're really interested in seeing this stuff, again, you don't need to buy the DVD to study for the exam. I will show you all the histology that I will use to test you. But if you want more information, you can always go pick it up. But these purple and pink samples that you see a lot of them. This is called hematoxylin and eosin stain. Hematoxylin and eosin stain slides, or what we abbreviate as H&E slides. It's a very generic stain. The pink color stains extracellular matrix, like collagen. The purple color highlights nuclei. So when you see a high collection of purple dots, you have high cell counts in that area. You guys with me? So in this particular slide, you can see we've got normal on the left, normal stomach duodenum interface, but we have these structures known as Peyer's patches. Peyer's patches. Now these Peyer's patches are lymphatic tissue, and they were originally discovered in the 17th century by a Swiss anatomist whose last name was Peyer, Johann Peyer, or Johann Peyer, most likely is how you pronounce that. And these are lymphatic tissue where they're collecting anything that might be foreign that's coming into your body, which makes sense. Gastric emptying, stomach contents after you've mechanically digested and mechanically broken down and chemically digested everything, it goes into the small intestine. That tube is still considered outside the body. So if you're going to absorb stuff across that epithelium, you're going to want these cells to screen. This is the lumen where the food or the chyme would be. You want those cells there in case there's some bacteria or something that's problematic, you want them to fight. That's your first line of defense. That make sense? So that's why you have them there. So that's the normal architecture of these Pyrus patches. Well, the slide image on the right is a chronic peptic ulcer. So in this particular slide, do you see this epithelium organization? You can see the microvilli. Do you see all the folds and invaginations of the intestinal lining? You guys remember that? Kind of looks almost like finger projections to increase the surface area for excretion and absorption. And you see you lose all that, right? It's gone. And all of this is becoming disorganized. These are the same magnification compared to here. You've lost Pyrus patches. There's no structure that has a high cell content. These are a collection of lymphoid cells or lymphocytes. You don't even have any Pyrus patches here. And then if you move into the epithelium up here, all of this collagen organization is disrupted as a result of this chronic peptic ulcer. Now, what's happening there? It's the same thing that's happening on the proximal end, is happening on the distal end. If you have gastric emptying that's happening too quickly, right, downstream, you can actually ulcerate the intestine. Now, one of the reasons gastric emptying might be premature in patients is if they have high stress levels. And so that's why you hear the saying, hey, don't worry so much, you're going to get an ulcer. Well, this is microscopically ulceration of the duodenum. Okay? So today we're looking at regurgitation up to the esophagus being a problem, and we're looking at gastric emptying too quickly or prematurely into the duodenum being a problem. So two pathological states that are very, very similar. This one doesn't lead to an adenocarcinoma like what you see in the esophagus, but this one does lead to bleeding ulcers in the duodenal tissue. Question in the back.
This has to do with the sphincter as well on the lower end of the sphincter?
Yeah, on the summit. Yeah, so it'd be it's the pyloric sphincter, I think, right? Is that correct? You guys, am I accurate? Yeah.
Is that because the hydrochloric acid is also leaking back the other way, basically?
Well, it's leaking forward stream, but it's leaking before it should. Or the sphincter is opening up prematurely, like premature sphincter opening. Sounds like a bad condition.
But you were saying that we have
PSO.
You were
Sorry,
saying
that was bad.
we have goblet cells still there, so when it be able to kind of protect the cells, like why does it get disorganized if it already has?
Good question. Aren't there goblet cells in the duodenum? Why can't the duodenum handle this? That's a great question. Right? We don't have goblet cells in the esophagus, so they make goblet cells. Here you've got goblet cells. Why can't it handle the acid? Well, the problem is if it's emptying the contents too early, the concentration of HCl is too high. Right? Because so chemical digestion of the food should happen in the stomach. Once it's over, the acid is neutralized, and then when it exits, you have not a neutral pH in the duodenum, but you don't have nearly as acidic of a pH in the duodenum. So the duodenum might be slightly acidic to slightly basic, but the pH probably will be somewhere between like 4 to 6. Whereas in the stomach, you could have pHs in the acidic range of 0 to 2. So if it empties prematurely, you're getting just a higher concentration of acid in the duodenum, which it just isn't designed to handle. Yep. Good, these are phenomenal. You guys are, I know you guys think I say this to everybody, but you guys are asking really bright questions. Okay. This is where we go through some video editing.